Good morning and good afternoon from wherever you might be right now. We're coming to you live coast to coast. My name is David Saucedo. I am a NHMA board member. I am a licensed attorney both in Texas and New Mexico, and I am the president of the Saucedo Company, which is a 100-year-old family business located here in the world famous West Texas town of El Paso. But enough about me. Thank you for joining us today as we continue with this series of our town hall series for Salud+Policy. This is episode number 3, protecting the progress of our federal health agencies. The goal of today's discussion is to educate NHMA members and network partners about recent changes in our federal healthcare agencies, how to navigate this evolving landscape, and the potential impacts on the daily work of our physicians and healthcare professionals. The virtual town hall series aims to bring together NHMA experts to share insights and resources that support healthcare professionals and contribute to healthier communities. Before we begin, we have a few housekeeping notes. There are many of you in this chat, in this Zoom, so the microphones will be muted. However, I've been tasked with keeping an eye on the chat. So if you have a question, go ahead and put them into the chat, and we'll do our best to address those. And the way we'll start is we'll have introductions and opening remarks, and then will come your Q&A. But please feel free to put your questions in as we go, and I'll keep an eye on those. This webinar is being recorded, and all registrants will receive a link to the recording afterwards. And of course, you can find it on our website, nhmamd.org, and our YouTube channel. So without further ado, let's get started. The National Hispanic Medical Association is a nonpartisan, nonprofit member association founded in 1994 in Washington, D.C. That represents the interests of 50,000 licensed Hispanic physicians across the U.S. As a national leader in improving Hispanic health, NHMA empowers physicians to address health disparities in collaboration with medical societies, students, and key partners. Through advocacy, education, and partnership, NHMA works to create healthier communities for all. So why are we gathered here today? To get us started in this discussion, I'd like to give insights on the conversation we will be having today. As I'm sure you have seen in the news cycle lately, over 10,000 CDC and FDA workers have lost their jobs in the last 2 months, and the total HHS workforce is expected to drop from 82,000 to 62,000 people. The National Center for Chronic Disease Prevention and Health Promotion was reduced by about a third, eliminating the Office of Smoking and Health and the Office of Oral Health, the Office of Population Health, and the Office of Health Equity, and some reproductive health divisions. The National Center for HIV, Viral Hepatitis, STD, and Tuberculosis Prevention lost about a fourth of its staff, with the biggest cuts coming from the HIV Prevention Division. These cuts include researchers, scientists, doctors, support staff, senior leaders, leaving the federal government without many of the key experts who have long guided U.S. decisions on medical research, drug approvals, and so on. Cuts to FDA leadership and administrative staff handling bird flu outbreaks, tobacco prevention, HIV prevention, and potential abolishing of NIH research divisions, and enormous budget cuts across the HHS is extremely concerning. And I think we have a slide here that'll point to some of these statistics, as you can see on your screen. To further NHMA's mission of supporting physicians and healthcare professionals to improve the health outcomes of all underserved populations, we have convened top experts in these areas for a candid discussion today on how to navigate through this precarious time. I would like to thank and introduce our panelists today. Dr. Audrey Escobedo Vice President of Clinical Research at the Emerson Clinic Research Institute, Inc. Dr. Fabian Sandoval, President and CEO of the Emerson Clinic Research Institute. We're also joined by Dr. Mark Alain Drey, infectious disease physician and co-founder 102.3 FM WHIV LP radio dedicated to human rights and social justice. And lastly, I'd like to introduce Dr. Jose Calderon, a general pediatrician at renowned Children's Hospital, associate professor of pediatrics at the University of Nevada, Reno School of Medicine, and immediate past chair of the NHMA Nevada chapter. Let us start off with the topic of NIH and research, as this will impact our other topics of HIV and tobacco prevention later on. Dr. Audrey and Dr. Sandoval, please give us some background on your specific work and how the reduction in force across federal agencies impacted you as experts in your organization. We will now begin with our opening remarks. Thank you. I don't think we can hear you. Go ahead.
You want to start with us?
Yes, please. You guys go ahead and begin. Dr. Audrey and
Great.
Dr. Sandoval, the floor is yours.
Thank you. So thank you for, first of all, NHMA for setting up this very, very important discussion that we as Latinos need to have with our colleagues and healthcare professionals in the industry. The way this has really affected us, if we speak just from the federal level, what's happening in clinical research and the fact that so many institutions, departments within the FDA have closed down is dramatically impacting the review, approval, adverse events, everything associated with the clinical trial is what's going to impact us the most. And we're seeing that already with the pipeline of studies that are coming through, the ability for even other companies and other pharmaceuticals or public sector activities which are being slowed down, and it's really going to impact our health outcomes and development in. I think that is the largest one that we're seeing right now.
Yes, as well as the funds for some pharmaceutical companies, but also for research sites. We some of the research sites depends on federal grants. We know that most of them have been cut dramatically, and a lot of the patients who were enrolled in oncology studies have been lived without any type of treatment. So it's not only impactful in the economic but also in the health of the patients who were already enrolled and other patients who were looking forward for the new studies, new treatments that were upcoming.
We'll fill in the gaps as we kind of go through the discussion, but that's kind of our opening remarks as to what we see. And then we can talk about the fact that the reason why we're seeing a diminishing amount of patients showing up to our community research activities. Patients are concerned about that. We can go into that. And that's not just seen here in our headquarters office in DC, but we're seeing it across the country. And I say this because I'm also part of the leadership group within the Society for Clinical Research Sites, which represents a huge amount of research sites across the country and the globe.
Got it. Thank you all. I think this is a tremendous opportunity here for our audience to go ahead and participate with you all and ask some questions. In the meantime, I'll go ahead and ask some questions here, but I think we should certainly take advantage of your knowledge and your breadth of knowledge here. I want to discuss kind of some notes here, the progress with again, HIV in the past and future prevention. What do you all foresee? Current landscape, maybe specifically the CDC. What are your thoughts? How do we navigate through that? What are the steps that you all are taking in the next foreseeable future?
Regarding what?
HIV prevention, just in general, like assuming we continue to go down this path of cuts and things. What can we do? What can others do? What advice do you give to the clinicians and doctors here in the group today?
So what we're seeing is, because there's so many cuts, there's also cuts in education. Besides the work that we do within our Clinical Research Institute, we also have a national, one-of-a-kind TV show that's called Tu Salud, Tu Familia, in which we are dedicated to educating the community. And when our funds are reduced, not just within our show, but anywhere that has to do with community education, community outreach, if we're talking about HIV/AIDS prevention or awareness, that's going to be cut. That we're going to start seeing that here in our area. We're going to see that, and the problem is with the growing youth that we have and the influx of patients. They may not be aware of what's available as preventative care or current prophylaxis for this type of condition. And that is going to be a wave of new cases that we're going to see if we are not able to properly educate within the cultural competencies of our patients, keeping in mind that there might be language barriers, cultural barriers. You know, there's a lot of stuff that's kind of kept underground because families don't want to share this information. So that's kind of the things that we're going to be seeing.
And I think we spoke on offline about your program that you have, and I do want to get into that a little bit later. I think that's fantastic. But I want to kick the ball over here to Dr. Deary. Given your background here, what are your reactions to these cuts and the impact for physicians caring in this space?
Yeah, thank you so much. And I have that in my opening remarks. So my name is Mark Deary. Thank you. I'm an infectious disease physician, an epidemiologist, and really all in all, a public health nerd. And for the record, I'm still that 57-year-old guy that still rides skateboards to work. That's who
great.
I am. So I spent the better part of my career in the trenches of HIV care and prevention, from the vibrant streets of New Orleans to communities worldwide. And if you want to know what really motivates me, it's simple. Is I believe everyone deserves a shot at a healthy life, no matter what their zip code or their background is. So my journey with HIV began actually when I was quite little. My father was an HIV doctor in Los Angeles. He didn't become a doctor to do HIV. It just kind of fell in his lap. And for me, what he taught me, because we're from Morocco, my dad didn't understand homophobia and, the early 80s stigma. That was not the life he grew up in. And he taught me justice, and he taught me the power of what stigma is, and he taught me the power of community. That was one of the reasons why we named our radio station WHIV. Those three letters, when they're repeated, 4 times an hour, 24 hours a day, 7 days a week, 4 weeks a month, 12 months a year, for 10 years, you will decrease the stigma associated with HIV, because WHIV said over and over again, how do you decrease stigma? How do you take the power out of a word? How do you take ownership of that word? And that's what we've done with WHIV. But I've started 2 Ryan White clinics in New Orleans, and we did it with the radical idea that people shouldn't have to jump through hoops to get tested or treated. We offer same-day testing. We hand out medications where folks would take it at the time of treatment, and we also made sure that nobody felt judged for walking through our doors. We've seen the science work. Undetectable means untransmittable, and every suppressed viral load is a victory. But we're here to answer the question you just said, right? What's the elephant in the room? And so these cuts to CDC's HIV prevention budget, these fund 91% of HIV prevention in the US. We have seen 21% decrease in HIV here in New Orleans. My clinic systems have, the ones that I started, have been beneficiaries of these monies to prevent HIV. So this 91% of HIV prevention that are being proposed to cut, that's a big number. It's the backbone of our fight. These dollars support testing, outreach, education, and the people who make sure that our people living with HIV, our clients, don't fall through the cracks. So what happens if these cuts go through? Well, imagine trying to fight a fire with a garden hose. We'll see fewer testing sites, fewer outreach workers, and that means more people slipping through the net. In places like New Orleans, where we already have to face high HIV rates, it's like pulling a goalie in the middle of the game, hoping for the best, right? Spoiler alert, that doesn't end well. So for those of us on the front lines, it means that we'll have to be more creative. And I'm not saying we'll start holding bake sales or something like that for HIV testing kits, but don't tempt me. I've done weirder. We'll do what it takes so that we can get stuff done. We'll stretch resources, we'll hustle for grants, and we'll lean on community. But let's be honest, and let's be clear here. Public health shouldn't be a game of MacGyver. The real tragedy is that we have the tools to end the HIV epidemic. We have PrEP, we have effective treatment, we know what works. What we need now is a political will, and yes, the funding to finish the job. So to my colleagues, I know this is tough. We didn't go into medicine to become expert grant writers or to tell patients, sorry, the funding ran out. But we are resilient and we will keep fighting for our patients, even if it means we're getting a little scrappy and having to go to work on a skateboard. And to everyone else listening, don't let this be a moment where we turn the clock. We've come too far to let budget cuts undo decades of progress. So speak up, get involved, and remind our leaders that public health is non-negotiable. Thank you.
That's fantastic. I mean, what a breath of fresh air and energy that you bring to this, and I think we're very excited. Thank you for being here. I think this is we're here to support you in your efforts. Absolutely. Now I want to kick the ball over here for because another target of these cuts is the FBA and tobacco prevention efforts. So Dr. Cucalon Calderon, kicking it over to you. Given all your work in this space, can you fill us in? Of course, introduce yourself, tell us about yourself, but can you fill us in with some of your worries that you see coming down the road, especially in your space?
Well, thank you, and good morning, afternoon, everybody, no matter wherever you are. Very happy to be here. Thank you for inviting me and for the opening. I am a general pediatrician. Most of my career, one of the big things that I have been able to successfully do has been being able to recognize community resources to help the parents of my patients quit smoking, as well as being able to create strategies to deal with second and third hand smoke exposure in our health system, out of my clinic, as well as prioritize nicotine addiction prevention, utilizing community resources for our youth who show up with new tobacco products all the time. A lot of times with a revolving door of new things showing up. Now it's going to be a gum. Now it's going to be toothpicks. Now it's going to be pods that you put in your mouth. Vapes that now have, besides continuing to have very high nicotine and not irritating the throat, as well as flavors, that have video games now associated with them. So definitely understanding that this is a changing market and that the priority here is nicotine addiction rather than anything else, given that we are still selling to kids and kids are still able to get their hands on these products, place in multiple areas. So right now we know that tobacco is strongly associated with most causes of preventable death. It's the largest single contributor to preventable death in the whole United States and probably in the world. We know that we have close to 40% of children exposed to second and third hand smoke exposure. We know that parents who smoke and are pregnant, or parents who get second and third hand smoke exposure, have a much higher chance of having preterm birth, having low birth weight babies, ending up needing intensive care units. We know that kids who have second and third hand smoke exposure, who have the most common chronic disease in childhood, asthma, are going to end up having a higher chance of ending up hospitalized, more ER visits, as well as ICU care. So definitely looking at it from the kids' side of things, being able to have a way of supporting parental smoking cessation is really, really, really important. The other side of the fence is that the way that we are able to assess new and emerging trends in tobacco use has been by using the Youth Behavior Risk Survey, which was under the Office of Smoking and Health at CDC. So that not having that specific tool, which is how we figured out that we were seeing these trends going up for e-cigarettes, going to the all-time high of 2019. Then being able to identify, associate that with EVALI, and being able to recognize those trends in use, were integral in being able to continue doing surveillance of what different things are being used by our youth all the time. So having said that, We are talking now about cessation services. Absolutely. We are talking about new and emerging products. Absolutely. Then what is the third piece? The education. So prevention used to happen also through the Office of Smoking Cessation with CDC reporting that there were more people engaging with cessation services the second that they would see their TV spots for smoking cessation programs show up on TV regularly in their area. So being able to recognize that okay, I have this need and I should be looking at this, making it available is a big way that people would end up finding out about this. So we're talking about surveillance, we're talking about treatment, and we're talking about education.
And yeah, doctor, if I may, real quick, before we get into the more general questions for the group, I'm just curious. So, with all these cutbacks, and obviously we all know that the harms of tobacco. I mean, I guess we should know, right? But with all the cutbacks, what are the literal adjustments that you're seeing if you're in your rooms with the patients? Are you finding yourself having to talk about tobacco forcefully, perhaps? Are you bringing it up? What are you doing in your personal practice to combat some of these issues?
Well, not really. So the biggest change for me has been twofold. Number one, talking about smoking cessation resources that we have locally, which happen through the National Quit Line, including in our health district, which was the main way in which parents who didn't have a PCP, who didn't have insurance, would be able to get access to some quitting resources. That was normally with that whole program being under the Office of Smoking and Health. Right now, I am handing people a card for the program, and I don't know if people are actually being able to get any services right now. Right now, the other thing has been that we are waiting to see how the funding cuts end up affecting our office, because the final announcement was really very recent. So I'm still continuing to practice the way that I have, but I don't think that that's going to end up being sustainable once they announce what the changes were. Then the other part is that if we don't have the youth behavior risk survey moving forward, then we don't know if our kids are being taken advantage of by e-cigarettes, or if we are having to deal with youth with nicotine addiction as much. We might see it in clinic, but we don't have the large scale data that led a lot of our interventions and also our prevention practices over the last few years. Given that we know that there are companies that we know have gotten a lot of flack in the last few years because they were prioritizing selling to youth, and this is data that actually helped us get to that point.
Well, okay, and thank you for that. And I think I want to open it up to the floor here, and obviously, panelists, feel free to engage with each other, absolutely. But I want to get into the research. Dr. Deary, I want to kick it to you, because you said something that was very interesting. That it's like you all were doctors to find solutions, and all of a sudden you've kind of morphed into these potential grant writers and things that maybe you didn't ask for. Is there any good that could happen with people incorporating grant writing into their practice? What do you see? Because I mean, it sounds like this is something that you didn't necessarily look forward to, but now you're doing it. What do you think the long-term implications of having, again, clinicians, physicians, researchers start doing grants on their own? What do you think is going to come of this? And what do you see the future landscape being like with this really new area of your practice, perhaps?
Yeah, I mean, that's a great question. And I'm going to kind of answer that question, but kind of tagging on to what Dr. Calderon was just talking about, because what he brought up, I think, was probably the most important thing for us to consider, even with grant writing. And that is that our sources of data are being removed. I mean, if you think about it, like, I can't even get data on what the sexual habits or practices are of young people in the state of Louisiana, let alone people. Like, we can't teach. We're teaching young people here in Louisiana, as I'm sure as a lot of people in some of the southern states, the sexual education is based on lies, quite frankly, and we don't even have the information to know what to teach these young people. They've taken away any data with respect to what gun violence is in this country. So if you don't study the disease process, then you don't have the answers. The problem will continue on. The same thing could be said with almost every problem that we're talking about: environmental health, climate change, what have you. Now we're hearing about the same thing with tobacco prevention as well. Without understanding the problem, it's very difficult. And moving forward, David, to your question, it's going to become much more difficult to write grants. We don't even know what we're going to be writing grants for, quite frankly, without having that information. I think, if you don't mind me saying, probably a more related question is, how are we going to start collecting the data on ourselves so that we can write the grants, right? How are we going to unite as healthcare professionals, as public health professionals, so that we can figure out? I mean, we are already seeing it with police violence, right? I mean, nobody wants to police themselves, so you have The Guardian, which is a UK newspaper that is keeping statistics just based on the news for the last 10 years on police shootings to civilians on the streets in the United States. It's going to be a process like that, where we're going to have to figure out ways of being able to capture data so that we can write to funding agencies, so that we can get the money to do this. Again, I'm an advocate. I'm an advocate at heart. I've always been an advocate since I was 7, when I remember advocating for the first time. My dad took us fishing and he killed a fish. I didn't realize fishing meant killing fish. And I advocated for that poor fish that died on the boat. That was my first day of advocacy. But not every doctor is an advocate, right? They just want to go to medical school, right? They want to come home. They want to care for their family. They want to feed their children. They want to see grandbabies. They just want to live, right? And, I think it's unfair for us for those of us who didn't go to medical school to become advocates, now all of a sudden are finding themselves taking on extra burdens, because it almost seems like this is, we're pushing a stone up a hill, a very large hill, and it's a very steep hill, and I don't even see the top of that hill. You know what I mean?
I'd like to, kick it over to Dr. Escoto and Dr. Sandoval on this. But you bring up a good point, and maybe you all have some suggestions and solutions here, but it does seem like, again, you all are the physicians, you all are the experts, but it's fascinating to me that there isn't like a database that can help us compile things. It seems like everyone's working in silos. Any thoughts from the Emerson Clinical Research Institute on coming together on things like this? What do you see, again, in the foreseeable future, we can all come together and align our efforts here?
Well, I think that we as a research institute, and with all our colleagues who conduct clinical trials, we truly realize the impact that we've been having. It's happening. We have seen a decrease in new studies, a decrease in patients, and of course, a lot of the sponsors of pharmaceutical companies who previously had diversity staff members they had to change their titles. They have to cancel the programs they had for community outreach. So that has a very negative, path for the clinical trial development, especially with the cuts in the FDA too. We have seen a lot of the bad impact in terms of the grants for clinical trials, but also in terms of the development of the new medications. We are going back probably, I would say, negatively 5 years from now, because we have seen some studies that have stopped. The patients have not been able to finish the clinical trial. So I think that it's a negative impact, but as a research institute and the sites, we've been unified, and we've seen that we have to keep doing what we do. We need to keep enrolling the patients that we work for. We need to keep increasing diversity in clinical trials, no matter what, because at the end, that's the end goal of the treatments. We're developing treatments to treat these patients. If they're not enrolled, we will never know if the medication will work on them.
Yeah, and I'd also like to add to what Dr. Audrey was mentioning of what are we going to do, right? What's the path forward? There needs to be more collaboration, right? You do see the collaboration efforts in investigator-initiated studies through universities. When it comes to some of the private sector activities within research institutions, there may not be that collaborative effort. We need to partner. I am a strong advocate of partnering with other institutions. The more we partner up, the more we are strength in numbers. And that is the numbers that we need to push forward, is to do that. It's going to be hard. And David, your point of, I also want to mention a little bit about, is it going to make us better grant writers? Like Dr. Darius said, we didn't go to school to become grant writers, right? That's a whole nother career, right? For us to have our own businesses, we didn't go to school to become business people, but you end up doing it because if you want to succeed, you have to do that. I ended up having to hire people to help us do grant writing. I don't think it's the way forward for the ones that want to do. Each one has to do their thing, right? I learned something from my Cuban OBGYN professor que decía zapateros sus zapatos, right? Everyone gets stuck on their roles. So let us do medicine, let us do research, and let's collaborate with those grant writers so that we can do the next step. But if we don't collaborate, if we don't share our own data, you're not going to be able to put those numbers that you're trying to do so that we can put together some type of a grant. If there's even grant funds available, those are disappearing. There aren't going to be any more grants. There's zero government grants. Now let's hope for the private industry to see if they want to put out some grants, but they're not going to have any money either pretty soon, because the departments that do the corporate giving, they're going to be corporate keeping. They're not going to want to give anything out because they don't know if they're going to look bad in front of the government if they're supporting an institution that's helping out underserved people. So all of those things have to be kept in mind, and we can't shut down. We need to hold hands and communicate with each other. NHMA has a great role to do and bring us doctors together to do something forward. We've got great presenters here. We can deliver messages. We can put stuff together, but it's what is the final outcome? And the final outcome is getting good medications to market soon and not having the people who are on cancer studies waiting because the medications haven't been approved, and they're not going to get approved anytime soon because there's not enough staff within the FDA to do it. But we still need to find ways forward.
Can I add to that just real quickly?
Go ahead.
I'm
please.
sorry. I just also want to say, as those dollars, as you mentioned, are going to start getting thinned out, if you will, it's going to be harder. We need to think about this, okay? Like, we need to anticipate this. It's going to be harder and harder to collaborate because now all of a sudden there's less dollars out there, and yet we still have all of our organizations to support. And we need to figure out ways to get beyond that hyper competitiveness in this fields that we're going to be in all of a sudden now. And you're right, we need to stand united, holding hands. But man, it's going to be hard to do it. I really see that we are all going to become hyper competitive so that we can get whatever crumbs that are going to be thrown our way, so that we can continue to support whatever entities that we're part of.
And I think I think one of the little shameless plugs I'm going to put in here for NHMA is we understand the role that we have, and it's critical at this point, NHMA. And one of the things that we did was we resurrected the Policy and Advocacy Committee. What's interesting about that, and I can share this with you as a co-chair for that committee, is that to Dr. Drury, your point, even Dr. Sandoval, your point, you're right. You all didn't ask for this. You didn't ask to be doing things that are outside of your scope of practice, right? But one of the things that I found is that we're trying to get in a position to advocate for what we're doing in front of legislators, whether it be the federal government, even state, it doesn't matter. We just need to bring awareness, right? And there seems to be, and I understand it now, really, I'm clearly I'm not a physician, but you're right. There is this uncomfortable sense of this is not what I'm supposed to do. I'm supposed to do something else, right? And so I think let it be known to everyone watching that, again, the role of NHMA and other medical associations is critical. And I think you all as physicians need to hold these groups accountable to deliver the type of results that you need so you can continue your practice. Now, I'd like to, with that, we have a question. This is great. We have a question here from Patty Medina. Okay, I'm going to read it here. Patty, as a public health professional, I'd love to contribute to strengthening data collection or supporting ongoing research efforts in any way that I can. Are there opportunities for collaboration or ways I can be involved to help advance this important work? I see Dr. Jose giving his thumbs up. Can you go ahead and share us what your thoughts are on that?
Well, I'm not a public health specialist. I'm a physician, practicing physician, but the sentiment that everybody has shared here today, including Patty on her question of coming together, trying to actively collaborate with people, trying to find a way forward, is exactly what I have been hearing in pretty much every other group outside in my scope of practice, both locally and at the national level. So there is a shared sentiment here with everything, with all that you have said, and this allows for people to start having these conversations and to see what the shared goals are to be able to move forward. If I can comment also on a couple of things, we know that the United States is increasingly becoming more diverse. Okay? We know that the population has changed over the last 10 years. It's going to continue changing. We know that there is going to be even Latinos. We talk about Latinos all the time, but Latinos is a very widespread generalizing group of a lot of different people from Latin America that have their own stories, their own systems, their own beliefs, their own culture. So without being able to mirror or study and measure diversity, we don't have a way of being able to practice culturally humble care, culturally informed care. And that is highly concerning to me, as that is necessary to be able to meet community health needs, no matter where you are and with whom you practice. Lastly, we as physicians, we want to, advocacy means speaking up for your patients, okay? And one of the things that we have done over the last few years, knowing what our roles are, it includes also speaking up for our patients, but not being able to have the data to support speaking up our patients for a specific time until we end up being able to have that data available through different funding collaboration. Everything might end up leading to a lot of negative health consequences, and that's where I worry. I serve a lot of Spanish-speaking families here in town, and I can tell you that if half, if not more, of the parents of my patients don't have a PCP. They might not be documented either. And so that means that they don't have access to services. They don't have somebody who can help guide them on their own medical care. The Quitline was one of those few resources that I am able to do in my scope of practice that I could do to share and help everybody's health by having the person who had nicotine addiction receive treatment. So, and then you also have to think about the social impact of that. So when we know that living with somebody who has nicotine addiction and smokes negatively impacts everybody's health in that family nucleus. So what happens if you don't have access to that and you have a parent who is the money maker for the family, getting a heart attack, a stroke, getting cancer? What happens to the rest of the family? Who provides for them? So there is also a really strong social component that we are going to see moving forward. And in my case, we're going to see it as an adverse childhood experience for children. But this is definitely impacting the family nucleus.
Now, if I may, we have about 20 minutes to go, and clearly we when we prepared for this town hall, we had certain talking points we wanted to get out, and so I'm gonna keep an eye on the chat, but I'd like to panelists, if there's something that we're missing here on the questions you want to get out. I know we had some preset questions. If there's a point you want to make, let's make it. and let's stay open for some questions, because I think the conversation's been fantastic. I think it's been high energy. I think it went where it's needed to go. But I want to give you all the opportunity here to come in and discuss. Perhaps there's some points that we haven't discussed yet that are important to you. You want to share, and maybe we'll start the. I don't know. What do you think, Dr. Drew? You want to go ahead and kick it off? Is there anything that we haven't necessarily touched? And then we'll go. To me, it's counterclockwise, and we'll go from there.
Okay. Well, one of the things that I do want to kind of get to some of the ripple effects that the cuts on broader infectious diseases is going to have, including STI prevention. It should come as no surprise. I often tell people public health is not complicated. You do something today, something is going to happen later. So first thing we're going to see is an STI surge. HIV prevention programs, which are often the backbone of broader sexual health services like what I provide. These CDC-funded clinics, like all my clinics, are federally funded through Ryan White. They will routinely bundle HIV testing with screenings for syphilis, gonorrhea, and chlamydia. These are STIs or diseases that hit record highs in 2024, especially here in Louisiana, particularly Baton Rouge and New Orleans. So once we lose HIV funding, you're going to also lose that infrastructure that catches about 2 million STI cases annually. Mississippi has shuttered their mobile clinics, for example, that provide discrete STI testing in rural areas, and their closure is going to leave gaps that cash-strapped states just can't fill. We're going to start seeing fragmented responses. The CDC's Division of HIV Prevention doesn't just fight one virus. It shares staff, labs, and data systems with TB, hepatitis, and other STI programs. So slashing its budget weakens this shared armor. For instance, syphilis rates are up 80% since 2018. Let me say that again. Syphilis has gone up 80% since 2018. So these are tracked by the same epidemiologists that are now facing layoffs. And as one advocate puts it, you can't amputate a lower extremity limb and expect the body to sprint. And lastly, and I think probably most importantly, and this is certainly something we saw during COVID, is eroded trust. Community health workers that are funded by CDC grants are often the only providers that marginalize communities' trust. And in the South, where stigma fuels HIV and STI disparities, these cuts silence trusted messengers like My Brother's Keeper, which is a group in Mississippi, which saw a 40% drop in STI testing after their funding lapsed. Rebuilding that trust takes years, but losing it takes one budget line item at a time. So the bottom line, these cuts don't just trim fat, they sever arteries in a system already straining to keep communities healthy. And as Amphar warns, every dollar cut today could cost $400 tomorrow in avoidable treatments. Infectious diseases don't respect a budget cycle. They exploit gaps, and right now the gaps are widening. And I also want to just point out that since the cuts of USAID, there has been something like already 25,000 documented deaths. Since the cuts of USAID, there have been already 25,000 documented deaths that have happened in the most vulnerable areas of the world. So these are very, very serious things that we're talking about.
Okay, thank you for that, Doctor. Dr. Escobedo, Escuto, and Dr. Sandoval, what are your thoughts on this? And then I did get privately another question we'll get to, but I want to get your thoughts here on anything that you want to touch on and let this vast audience of ours know about.
Absolutely. I would like to add also that as a doctors and public health, usually during our medical career, we really don't learn about clinical trials. So I think that clinical trials is a very important arm of medicine, and it's an extension. It's one of the most important extensions of medicine that we really do not learn about it. And I think that we should, if we as practitioners do not know how clinical trials work, it's really important to understand the phases, what is safe for our patients, and to tell our patients that it's okay to participate in clinical trials. I think that this is a very good option in terms of new treatments. And usually patients, 80% of the patients say, I have never heard about clinical trials. I don't know what they are. But if my provider, if my doctor will tell me that participating in the clinical trial is okay, I would consider it as another. And nowadays that we know that a lot of our patients have lost coverage for some of the medications that are vital for their conditions, we really should encourage them to look for other options as treatment. And clinical research, I think it's the best way to approach to our community, to our patients. And also as providers, we should get a little bit more involved in trials too.
That's great, Dr. Audrey. I also believe, as Dr. Audrey was saying, is for those people who haven't done anything, I think Patty, her request of how can she support some of the work that is being done, how can you help? I think the biggest help that we need is to continue to spread the word, that patients need to continue to go see their providers. If they're able to put gas in their car and go get this annual service of their inspections, they need to do the same thing for their own bodies, because if they're not doing it, it's going to be more costly for them in the long run. It's hard, you know, and it's pretty easy for me to say, yes, go to your doctor. But today, someone in my office said, you know, in DC here, they're having right? They're starting to grab some people. So that spreads very quickly within the communities. So no one's going to come out. So it's easy, and I don't want to sound hypocritical, say just go, but you can't just go. It's very hard to just go, but it's up to community workers, if there's any still available, or these public health professionals like Patty, is to find ways to have patients still go to those trusted clinics. Like Dr. Derry said, you know, a lot of people are scared, you know, we're losing the trust. We have to continue to encourage the trust. If it means for us as providers to go and do home visits, we're going to have to do that. And my staff does that. We go to the patient's homes and do procedures that, you know, we'll have to draw blood samples or deliver medications or do something to help develop that level of trust where patients can come into a safe space to be seen. But we can't stop. And clinical research is going to be that one option for everyone else that doesn't have access, as Dr. Audrey mentioned. But it's easier said than done, but that doesn't mean it's impossible not to do it.
You know, and I think the conversations here have been very impactful. And you know, one of the things I want to share here with you all, and it's a question that we got too, is, you know, I do believe that all politics is local, right? At the local level, like you get a lot of stuff done there, being the boots on the ground. So what is your advice for individual physicians? What can they do to support Latino patients that are being, you know, impacted by some of these federal cuts at the very granular, personal, one-on-one level? What would you suggest? What is your advice? I'd like to kick it off with Dr. Cucalon Calderon with that first, and then kind of go around. And after that, we can get some closing remarks. But I do want to bring it home again with that one-on-one relationship, doctor and patient.
Speaking up for your patients, that's going to be a good starting point. How, when, who, in which way? Do you know what's going on? Do you understand what might be going on? Are you able to, do you have a coalition of people with whom you, or that you already have identified that you are talking about what these changes might be or what needs might happen? Medical associations can end up offering some of that coalition building and support. I personally am a member of the Nevada Minority and Equity Health Coalition, I'm a board member for the Nicotine and Tobacco Prevention Coalition for our state. I am at the Nevada chapter of the American Academy of Pediatrics. I founded and ran the NHMA chapter here for its first 3 years. So being available to be able to talk to anybody and collaborate about what those needs might be is a really good starting point. So recognize who is doing the same work, who might be seeing the same things and reaching out, having a conversation. Just yesterday, I ended up getting a notification that our local right now we are in the legislative session here in Nevada, and and I ended up submitting a support for a bill that was talking about changing opt-in to opt-out for our school district to actually give sex ed information and by here in school. So the body awareness is an important topic, being able to know about STIs, understanding that everybody should have access to that information unless they opt out. Was for me a priority, and along with what the American Academy of Pediatrics actually supports for youth. So recognizing those opportunities, if I hadn't been aware of it through my coalition, I probably wouldn't have been able to reserve time to present, give my comment, because you have busy lives. You have a full day job. You have a clinic. So what are you able to do, and who are going to be able to who in your circle is going to be able to help you being able to reach those advocacy goals and talk for your patients when they don't have a voice.
Great, thank you, Dr. During. Do you have any closing thoughts here?
Yeah, I do. Oops, hang on. Am I on mute? No, I'm not on mute. Sorry, I thought I was on mute. Yeah, of course. Yeah, I do have a couple thoughts. I do want to highlight the impact that these cuts will have on the Latino community in the U.S. as you asked. So, as we know, the Latino community is very vibrant, very diverse, and unfortunately has been carrying a significant share of the HIV burden for far too long. And, let's look closely that we recognize that Latinos represent about 19% of the US population, yet account for 1 in 3 new HIV diagnoses. So while the overall HIV diagnoses have decreased in recent years, they've unfortunately increased by nearly 20% amongst the Latinos. Young Latino men, particularly those who identify as men who have sex with men or who are bisexual, are at the very center of this crisis, with alarming numbers on the rise. So what do these cuts mean in practical terms? They lead to fewer clinics in neighborhoods where language barriers exist. That means lack of insurance already poses significant challenges. This results in reduced access to testing, prevention, and the culturally competent care that truly makes a difference. More individuals will be diagnosed later when treatment becomes more difficult and outcomes worsen. And additionally, stigma, already a significant barrier for many Latino families and communities, will grow as resources for education and outreach diminish. But the crucial point is this: we cannot end HIV and the epidemic in America without first addressing it within the Latino community. Experts in the field emphasize this, and the statistics back it up. We need to invest more, not less, in building a Latino HIV workforce and eliminating barriers to care and ensuring that every individual, regardless of language, immigration status, or zip code, can access testing, treatment, and support. And as these cuts are implemented, it's important to understand this is not merely a budgetary issue. It's fundamentally about health, equity, justice, and our dedication to every community in this country. The Latino community deserves better, truly. And I assure you that as long as I have a voice, I will continue to fight for all communities, Latino communities, everybody, to receive the support that they need.
Thank you, Dr. Now, Dr. Audrey, Dr. Sandoval, any closing thoughts here on today's session?
I think it's this is just the tip of the iceberg when it comes to outcomes that we are going to see. This is 100 days. I think it's 102 or 3 days into a typhoon of health and equity. So either we're going to do like Noah's Ark and start building something that's going to save us all, but unless we get together to build this together, it's not going to happen. We need to start finding ways to contribute, right? And these types of discussions have to be more than we should be doing. We should be leaving this conversation with actions in hand. So simple actions in hand that we need to do now is to find someone within your district to start collaborating with, so that you have this power in numbers. And numbers can just be 3. It doesn't have to be masses, but you need to start building that momentum. I'm really concerned that we're going to have a a lack of new medications that are going to be approved that could be doing better for our communities right away because of the lack of support that we're seeing within the federal government when it comes to approvals because of the amount of people available. I think there's opportunity for all of us to continue the mission, and those missions are done by short activities, by pre-screening, still doing health fairs. Don't hide from the health fairs, still do them in strategic ways. We love churches, right? Latinos love to go to church, do them inside the church where there's those abilities to do even mobile units, right? We have a mobile unit here in DC, and we're planning on taking it out to the consulates, because if we collaborate with those leaders show that they have our backs. We're fortunate to be working with Mexico, Guatemala, El Salvador, Peru, Bolivia, Honduras in those efforts with those communities. So do that. Start talking to those leaders so that you can go to those consulates and start to educate and treat or pre-treat or pre-screen patients in those safe spaces.
Well, thank you all. I think this conversation has been fantastic. I think we can talk all day about this, and I think the passion that the panelists put together today is something truly remarkable. We're going to go ahead and record this. It is being recorded. We'll put it up on the social media sites for everyone to come together and watch. But you're right. I don't think the conversation should stop here. I think we need to continue and advocate. So I want to thank our guest speakers, of course, for their time and expertise on today's topic, as well as our live audience members and participation. And we got some good questions in today. You'll receive information on this recording. It'll be out there. Please share it. Share it again. Tell people about NHMA. Tell them about the work that we're doing. There's a lot of work to do, and honestly, we're just getting started. If you like to continue to participate in these town halls and these discussions and hot topics, just scan this QR code right here on the screen, and that'll get you ongoing updates. We're doing this on a monthly basis. There's a lot to talk about. We're certainly having a lot of fun with it, because I think that's what we need to do. We need to really bring these topics to the forefront, have a good, active, robust conversation, and hopefully empower all of you that are watching it to go do something and get active in your communities and do more, and hold us accountable to NHMA. Of course, we want you to become a member. We want you to join NHMA, join it today, and connect with healthcare professionals working to improve health outcomes for Hispanic and Latino communities. Once again, scan this QR code and become part of our mission-driven network. We are a very proactive group. We have great leadership. We have a great board, great staff, great committees. And I'm not just saying that because I'm a part of it. I really enjoy the work that we're all doing. And as you can tell, just with today's conversation, the work is vast, and we have a lot of work to do here. Next is we have a conference coming up. So join us in Anaheim, California on June 5th through 7th, where we'll be hosting our 20th annual conference. Make plans to attend. Once again, we have another QR code there. So please scan that. Hopefully we can see you all there. And once again, thank you to our panelists. Thank you for taking your time. Thank you to everyone for joining us today. And until next time, until next month, we'll see you then. Again, this is David Salcedo from El Paso, Texas, and we'll see you soon. Take care.